Hey everybody, it's Kate Seagroves. I'm doing my methodology presentation, skills presentation. I'm gonna do IV access and medication, just talk a little bit about medication administration and what to do if you can't start an IV. Trent gets to be my guinea pig, although he won't let me stick him. Although I have before. But so just a little bit about IV access. There's lots of different areas that we can access to administer fluid, to administer medications. I think starting IVs is pretty safe to say something we do on most ALS patients. So most patients that you have an advanced or a paramedic attending in the back of the unit, we are starting an IV on them. One of the most basic things that I talk about with any of my students is it's really important to start low and work your way up, because for any of us who have had to go back down, we may have seen some bad outcomes where if I have stuck high and then later had to go low, it's possible that my fluid is going to go in one and come back out the other if you're in the same vein stream. So Trent's got pretty good veins, although I have seen people miss on him before. But just kind of taking a look, different hand veins on men especially can be really difficult, especially ones who work with their hands a lot. Their skin can be really, really leathery and not go well. Men like Trent who have all of this stuff on their arm, it can be in the way. So you may have to take that out of the way. Removing all this stuff, but I guess show on me, there's usually a pretty good vein that runs starting in the thumb and it'll go all the way up. You can't necessarily see it very well just looking, but once you tie a tourniquet, you can feel it. And the best description that I've got is it feels very spongy when you touch it. Is the rest of the skin is different, and when you feel a spongy spot, that is usually a sign of a pretty good vein. So just starting at the beginning, most importantly, you know, just like with anything, scene safe, you're gonna wear your PPE. So I'm gonna put some gloves on, and then I'll kind of go through all of the different equipment and what we've got. Me personally, I like to get everything ready before I start an IV. So I'm gonna grab my extension set and a flush. Gonna open my extension. There's a small cap at the end and they tend to get lost. So what I typically do is when I remove this cap, there's a few different ports. This is our needleless port. I screw the cap there. That way, if for some reason I connect a tin drop and then I need to disconnect it for some reason, I'll always know where my cap is. It also keeps that site, if I were going to use my needleless port, clean, where it's not getting anything on it. Next, I'm gonna open my flush. So I'm gonna take the top off. I don't need that anymore. And this is gonna screw in. Next, I want to flush my line, so I'm just going to press gently on the top of the plunger until I see a few drops come out the end. I have a cap here. I personally leave this on until the last second to keep this sterile. So I normally would set this on the bench seat beside me. Next, I'm going to open my IV start pack, depending on who you work for, whether you're in a hospital or in EMS. They all look pretty much the same, but I'm just gonna pull this back. I normally keep it attached where I can lay stuff out. Different people use tape differently, depending on how many pieces you like. I normally have 3 ready, and I will just stick them to the side of the surface right in front of me where I can easily access them. Also, if the person I'm starting an IV on is quite sweaty, I normally will grab a 2x2 wrap, or if it's a child, someone who I'm concerned is going to rip my IV out, I go ahead and have that ready. That way I can really secure my IV and not be concerned that I won't be able to get it later. So tourniquet, at least ours are blue. I've seen them come in different colors. Again, like I said, it's really important to start low and work your way up. So when I first tie my tourniquet, I'm gonna do so kind of mid forearm. I kind of warn my patient, this is gonna be tight. It may pull the hair on your arm, I'm sorry. If I have an older patient, what I typically do if they're wearing long sleeves is I will tie the tourniquet on their sleeve versus directly to their skin. And depending on the patient, I'm gonna have them make a fist and hold it for a few seconds. And then once they release it, it's gonna make it easier where I can see the different veins. So on Trent, not sure how well we can see because the lighting in our kitchen is not great, but there we go. You can see there's kind of some veins popping up here. That would be a good one. There's some smaller ones in here, but I'm not sure how well you can see it, but there's a valve right there and I want to avoid that. So that's kind of some hand veins. Good for medication, things like that. But if I'm trying to give quite a bit of fluid, say hypotension, something like that, I'm not going to want to go for a hand because you typically can't put as large of an IV catheter in that area. So on Trent, he actually has some really good veins back in here, but again, it's really awkward. So I would say those are more of a last resort. Your AC is going to be where you can give medications quickly. Also where you can dump the most fluid at the fastest rate. A few of the medications that are preferred to go in the AC would be like adenosine. If you were trying to administer adenosine, say for SVT, they say you're going to slam it, meaning I want to push it as fast as I can. And these large veins in here are going to be the best place to do so. So not sure, again, how well we can see this because kitchen lighting not great, but I'm going to feel for this spongy area. He's got a really good one there. He's got a pretty good one in here as well, but it's deep, which is more difficult. Actually, the best one is probably these two here. And at least in my experience, that typically is how men are, whereas women typically right in the middle is the safest bet. Is that tight? All right, so being that he's not gonna actually let me start on him, I'm gonna go ahead and get out my IV arm. Probably should have done that before, but that's all right. We'll make it work. Kind of while I'm getting this out, a couple other things to talk about, different choices for fluid. Depending on when you started your medic is going to be whether or not you're going to use, well, maybe we don't have an IV arm, is whether you're going to use normal saline or lactated ringers. I typically use LR only in OB situations or trauma, but it certainly has other times that it can be used as well. But for the sake of this presentation, being that I had access to expired medications, when I show you how to set up, I actually have dopamine, so we're just gonna have to pretend that it is normal saline. So again, I'm gonna come here and I'm going to tie my tourniquet. Again, older people, I try to use their clothing kind of as a shield, so I'm not hurting their skin. All right, so I've already got my extension set up. I actually brought home 2 different types of IV catheters. These are new for us. This one here And this has an auto safety feature. It also is good, in my opinion, for newer medics or newer advanced, because it is a self-occluding catheter, meaning once you put the needle in the vein and you remove the needle or push the button to auto retract, it's going to occlude in the catheter itself, meaning you're not just going to have free-flowing blood, which you definitely don't want. Not only does it make a mess, but your patients typically don't like to see their own blood kind of flowing everywhere. These needles also have a safety feature. Once you take them out, there's kind of a blunt end to prevent you from sticking yourself, but the others certainly are a little better. The other pieces that come in our IV start pack is going to be your alcohol prep. There's also a betadine. So betadine would be really important if you were accessing, say, somebody's port where you can clean it twice. So you're going to clean first with the alcohol, then with the betadine. But for just a regular everyday IV, I do not use the betadine, so I normally throw it out. But I'm going to open up my alcohol prep. I'm going to clean my site, which this mannequin I could probably put a 14 in, but today I have an 18 and a 22. Just talking a little bit about the different size IV catheters. Your 14s and your 16s are going to be your trauma patients, where I'm needing to give fluid very, very quickly. Cardiac arrest patients, typically, once they've gone into cardiac arrest, you're not going to have that kind of access, but it is possible. I did use a 16 just the other day on a cardiac arrest patient. Your 18s and your 20s is what you're going to use most commonly, and then your 22s and 24s, as the number goes up, the size of the needle goes down. So a 22 and a 24 would be your elderly patients or children. So I've got my site all cleaned. I've got my gloves on. I'm just going to say, for the sake of demonstration, that I'm just starting to give just a fluid bolus. So my patient might be slightly hypotensive, something like that. A 20 is going to be enough. So again, I've got my tourniquet tied. I'm feeling for this spongy area. Your veins are going to pop up. I've got my needle here. You just want to slightly unscrew it, just the littlest bit. I'm going to go in at a 45-degree angle with my bevel up. I'm going to start just a little lower than I want to poke, and I'm going to slide my IV in. Once I feel it puncture through, and you will feel it, I'm going to use my other hand and come up and advance my catheter. Once my catheter is in the spot that I want, and what's going to happen is I'm going to see blood back up into this clear chamber. So once that's happening, I know I'm in the right spot. I'm going to hold my thumb just above to occlude, and I'm going to pop my tourniquet. If I don't pop my tourniquet, I'm going to be essentially creating pressure that's going to make this blood flow back. Now again, if I were using the other catheter, the thumb is not necessary because the catheter is going to occlude itself, but in this case, since it is, I'm going to use this hand here. I'm going to remove. This is the safety tip. You kind of see where even if I stab him, I'm not really stabbing him. You're going to want to make sure to go directly to a sharps container. Don't want to put that on the floor where it can harm anybody. This cap now is when I'm going to remove it. Some people say it's difficult to remove it with one hand. I guess if you've done it enough times, it gets easier. Just going to set that off to the side. I'm then going to line up here on my catheter. Then I can remove my hand because it's preventing it from flowing blood backwards. I'm going to hold this here. This is when you can check to make sure that you're going to get good blood backflow. So I'm going to pull back, and I'm going to be able to see blood coming up into my tubing, and then I'm going to be able to flush. It's flushing no problem. It's coming out the back of the IV arm, not that you can see that on this dark table. And it's up to you on how much you're going to give. I typically will lay it off to the side either way, Again, you're never going to want to remove your hand. So I normally have this peeled back ahead of time, but you're going to apply your Tegaderm, remove the tape piece, and then you're going to come in with your other pieces of tape. Me personally, I prefer to come underneath, depending if I'm in the AC. So I'm going to come underneath and kind of use a butterfly to secure there. And then use another piece of tape to come up here further. If I were going to then administer fluid, I've got this locked off so I don't have blood backing up. Typically they don't back up too badly anyways, but it's possible. Remove the bag. Again, this is not normal saline, this is dopamine, but there's going to be kind of a plastic on the bottom that you're going to have to pull to get to the port. So I'm going to open up my 10 drop or a 60 drop. A 10 drop is the best for fluid, in my opinion. I'm going to remove the cap from the end, and it's going to go directly into this hole. If you twist and push, you'll see it's going to flow through my tubing, and as soon as some comes out, you can roll down the blue piece here. And then I'm going to take this cap off the end. I'm going to remove my flush from the end and hook this up. Once that's in place, I'm going to hang my fluid. I'm going to turn it on slightly here and then come and unlock my extension tubing. And then I'm going to roll this back slightly until I see it start to drip. Depending on how quickly you want to administer, you're just going to roll this bar back and forth. This blue piece actually does move. I recommend you put it as high up on your tubing as possible. That way you can see it, easily access it. It's not going to get buried underneath your patient, anything like that. And then you can use your third piece of tape to put it up further up the arm and secure it just to keep it from swinging for the patient. I guess that's about all I've got. I'm assuming he doesn't have any questions, and he can probably tell me that he can do it better. But anyways.
Probably.
Have fun, everybody. We'll see you in class.